uh, this is like a labyrinth for me because we have so many techniques, so many studies done, and I have to say, for me, it's difficult sometimes to decide between these different techniques. And I try to make it simple, just to inform the discussion. The factors I use in this decision are patient-based factors and also lesion factors. And starting with the patient-based factors, I use a non-stent DCB strategy in patients who are young, who can probably come again for a restenosis, and these patients are mostly claudicants. But if I have to treat a patient with a CLTI, and this patient is old and is frail, well, I would like to perform a one-shot intervention, make the best so that the patient can go home and enjoy the rest of his life, which is very often very limited, as we learned yesterday by Dr. Peltrunas. Now, going back to the type of the lesion, we have different lesions. It's important to know what is the location of the lesion. If we have a flush occlusion of the SFA, we have a long or short lesion, a CTO, and last but not least, a very calcified lesion or not. And in case of short, de novo lesion or with the moderate or mild calcification, where the strategies from my perspective is simple. I use PTA first and I go for DCB. And I would implant a drug-eluting stent only in case I have a severe dissection or a severe recoil. And this is supported by many studies you see here, the efficacy of DCB for such type of lesions. If the lesion is short or very calcified, well, PTA is not a good solution in my opinion. We need a vessel prep and then go for DCB if possible. Or if in case of dissection or a recoil, go for drug-eluting stent. And the technique of the vessel prep is different if I want to go for DCB or drug-eluting stent. For DCB, as mentioned by Dr. Baha before, it's important to remove the calcium so that the drug can really reach the vessel wall and avoid a restenosis, as showed by different studies here by Dr. Fanelli and by Dr. Tepe. If we have a long lesion and the calcification is moderate, well, PTA, it's possible. It's also possible to use a drug-coated balloon, and as mentioned in case of dissection or recoil drug-eluting stent. But we should be aware of the longer the lesion, the higher the risk of bailout stenting. As you can see here, if the lesion is only 10 centimeter long, the risk is by 25%. But if it's longer, as you can see here, well, the risk will be 40, and in some studies up to 55%. So, uh, in case of old patient, frail patient, and so on, I would go straight forward and implant a drug-eluting stent. What about the long lesion with the severe calcium, with CTO, with restenosis, not after stenting, but after PTA or after DCB, where in this case I would make a vessel preparation and implant straight a drug-eluting stent. And I would prepare the lesion very well to avoid recoil, to reach an optimal stent expansion with the dedicated balloons or with the high pressure anyway. So this is this drug-eluting stent for such very long lesion. is the optimal solution is showed by the sports prospective randomized study comparing DCB, bare metal stent, and drug-eluting stent. As Baha showed, the results after drug-eluting stents in such very long lesion are really good, and even after 24 months, we have a superiority of drug-eluting stent compared to DCB or bare metal stent for such long lesion. Is an hybrid DCB and bare metal stent, perhaps a short bare metal stent, a solution? Well, I found the only prospective randomized study evaluating Supera with and without DCB, and you see after 2 years we have a primary patency after Supera of only 48%, can be increased with the use of DCB up to 55%, but in my opinion, this is not a good solution for such patients. In summary, uh, patient-based and lesion-based factors both are important in our decision making for treatment of such patients. The longer the lesion, the higher the risk of additional um, um, uh, bailout stenting after DCB, and the new generation of paclitaxel eluting stents show very, very, very good results in, or even in complex and long lesion. But it's important to make an aggressive lesion preparation to allow stent expansion and avoid recoil and restenosis during the follow-up. Thank you very much for your attention.
Thank you, Professor Torsello. Please join us. We move to the next speaker, Dr. Abdelhamid from Egypt, primary stenting versus bailout stenting angioplasty. Oh, sorry, wrong line. Management of Dr. Ahmed, management of instant restenosis, better devices or better patient selection. We don't. It's not. It's not. We move to the next then. So, as mentioned.